think we'll get started. So thanks all for joining this afternoon. This is the 5th installment of our shared learning series for the Diabetes Inside, No Diabetes by Heart program. We're going to hear from the Jefferson team, the primary care team, who's been working on adherence and statin use program to reduce CV risk. I want to thank our sponsors, our founding sponsors, Novo Nordisk and BI Lilly, and our national sponsors, Bayer, Sanofi, and AstraZeneca. And without further ado, we'll pass it right on to the Jefferson team to share what they've been working on for their QI work, and then we'll have a discussion at the end. And this is being recorded for those who couldn't make it today, so we'll post this online when we're ready to go. So without further ado.
Great. Tammy, you want to bring the you driving? There she is.
Andrew's driving.
I am.
Andrew's driving. All right.
She's an excellent driver.
Excellent.
Hear it all the time.
All right. So, well, thanks for the opportunity to talk and share with you what what the team's been working on. We have most of us on here. I think Bracken's the only one that isn't on here today. But we have a multidisciplinary and interprofessional approach to a health coach model to reduce the risk of coronary events in diabetic patients. Next slide. So our goals are pretty broad, but to improve the health outcomes for patients with uncontrolled diabetes, utilizing a multidisciplinary health coach model.
Join the meeting.
And we'll explain exactly what those mean, and specifically addressing complex barriers to patients in achieving their optimal health outcomes. Next slide. So the main site is at 9th and Chestnut. It's Jefferson Internal Medicine Associates. It's the main academic clinical practice for medicine and Jefferson Health in Philadelphia and Center City. It attracts a wide variety of patients. Really, it's, I've worked in a variety of sites, and this site really gets a slice of just about everything. We have very complex, underrepresented patients, and we have the highly high socioeconomic status, and we have really kind of everything in between, a good mix of commercial and federal payers. It has been a patient-centered medical home for the past 10 years. It is a CPC Plus Track 2 site, so it has a whole mix of support personnel from a pharmacist, mental health social workers, care coordinators, actually a couple MA navigators, one that helps with annual wellness visits. We have an embedded endocrinologist, 3 CRNPs. It's also the site for our sickle cell program, and approximately 14 internists and 17,000 patients in the practice.
So when we were looking to design the health coaching intervention, we really took into consideration a number of different factors. One, as Dr. Ward spoke about, the medical and social complexity of the patients who we were trying to support through this program, as well as the complexities of our healthcare system and the fact that clinicians are stretched really thin from an administrative perspective, also with the shift from fee-for-service to value-based care, the focus on quality metrics that clinicians are really trying to adjust to. And the fact that these patients, we have a short time with them when they do come into our office to see us, and there are a number of things that are going on in their lives that are preventing them from achieving optimal health outcomes. And so we took all of those things into consideration in designing our program. So as far as inclusion criteria, of course, we were targeting patients who receive their primary care at JIMA, patients with uncontrolled diabetes and hypertension. And we really wanted to focus from a medical perspective on our most high-risk patients. So we stratified them into 2 categories: patients who were at very high risk for a cardiovascular event based on their blood pressure and A1C, and patients who are at very high risk based on the same criteria. And in terms of our program workflow, so patients come to us through 2 different ways. One is the clinicians at JIMA know about this program, they're engaged in this program, they refer patients to us when they see someone in the office or they're communicating with a patient who they think would be a good fit. They reach out to Sandra, who's our health coach, and let her know that there's a patient who would benefit from our program. We also, based on the criteria that we have developed registries in our EMR and Epic so that we can identify patients and strategically reach out to those patients to let them know about the program and give them the opportunity to enroll. Once we've identified patients, we reach out to them to complete an intake form. We developed our own intake form for this program, and it's a combination of several different validated tools. The ARMS scale, the adherence to refills and medication scale used with permission, the Accountable Health Community Social Determinants of Health Screener, and the PHQ, as well as some general intake information. So we combined and consolidated those validated tools to develop our intake form, and then once that form is completed, based on the answers, we have a scale that indicates whether a patient should be referred to care coordination to address issues around social determinants of health or social complexity or risk, whether a patient should be referred to pharmacy for those needs, and whether a patient should be referred to behavioral health for any emotional or behavioral health needs. So those referrals are part of the intervention, as well as a health coaching program that we developed that can be completed either in person or via MyChart, which Sandra will talk about in a couple of minutes. And that really focuses on diabetes self-management, lifestyle modification. So we really focus a lot on the DASH diet and support patients in thinking about their overall health and how to make changes to improve their health and well-being, both through medication and through behavior. And then the patients at the 6-week mark, we do a check-in with patients to reevaluate where they are, the progress that they've made, and then either continue with health coaching or additional referrals, or ultimately, after a couple of weeks, discharge the patient from the program.
Great. So my name is Sandra. I am the health coach at JIMA. And since October of 2020, we've engaged 53 patients in our coaching program. Although not a large number, and certainly we hope to enroll more, but of those 53, 25 have achieved control, and 10 have improved their hypertension. So COVID has been a challenge for everyone, I'm sure. And the challenges that we all talk about here are certainly created by the pandemic. One of those is on-site patient enrollment. It's ideal to be able to catch patients when they're in the office and already engaged in conversations about their health with providers. Has been the preferred method to identify and connect with patients. However, because of COVID and social distancing concerns, we were not able to work from our practices as we usually would. So our solution has been reaching out to patients over the phone or MyChart. And reaching patients remotely has also been a challenge. Patients are sometimes reluctant to answer if they're not sure who is calling, or we're just unable to reach them during normal business hours. A solution for that has been Doximity, which I call Google Voice for healthcare, and it allows patients to identify the call as being Jefferson related with a 955 number or a 503 number, and that has certainly helped patients be more apt to pick up the phone and engage with us when we call. The commitment that it takes to be in the program is sometimes a barrier for patients. If you're offering coaching, they're wondering how much time it will take. Do they have the time to participate with other things that they may have going on? So being able to offer them options in terms of their commitment and how they engage with us has been incredibly helpful. For some patients who just want to participate in SMBP with a cuff that we are able to connect them with or that they have on their own, it's an option. Some patients, unfortunately, are not able to get a BP cuff, but would still like to work with a health coach around other goals. That is also an option. And patients that would like to do both. They would like to monitor their blood pressure, and they would also like to get information on health-related matters. Tracking patients is another challenge that we've come across in our program. We have used MyChart messages to follow up with patients. We find that leveraging this service is a lot more convenient for patients than just trying to decide on a day and time that works best for them to consistently be available. So communicating through MyChart has been convenient for patients and something that they've preferred to use. Capturing data that is helpful to us in understanding the progress of our program has also been a challenge. Jefferson has been awarded a grant through FCC that awarded us devices for home monitoring. So we've been able to provide patients with BP cuffs that sync up to their EHR. So being able to get readings at home from home has been incredibly helpful, I think, to our providers and for us to understand how our program has been helping our patients. And connecting patients with cuffs is a challenge as well, not necessarily related to COVID. Many insurances do not cover blood pressure cuffs, and so it's been a challenge to get patients a device. So the FCC grant, again, has been leveraged as a solution for this challenge, since we are able to award them to patients that have a smartphone. Fortunately, many patients do. So being able to provide them a cuff has been incredibly helpful to them and to us. So I thought I would talk about two of our patients that I've worked with to demonstrate how patients have utilized and benefited from our program. So Vera is 62 years old. She has hypertension, type 2 diabetes, and kidney disease. When I first met with her, her blood pressure was 141/102. So I provided her education, SMBP education. She has a blood pressure cuff at home that she was not using and was not familiar with how to properly utilize it. So we provided SMBP education so that she could take her readings consistently. We provided a referral to pharmacy so that she could learn about medications that she seemed to not quite understand how to take them or why she needed to take them in a very specific way. We encouraged her using a pill box. We've assisted with setting phone reminders and small strategies that helped her better remember and adhere to taking her medications. We also provided nutrition education resources that included a community-based referral for nutrition education, as well as information on the DASH diet, which she very much appreciated. And her blood pressure at discharge was 120/90, and she was very proud of her success, as was I. Mark is 57 years old. He has hypertension and type 2 diabetes. His blood pressure at intake was 154/79. He was also provided with SMBP education with a cuff that he also had at home that was not using. He was given a referral to BHC for our behavioral health consultants. He expressed experiencing a good amount of stress as being a caregiver for aging and sick parents. And a goal for him was weight loss. So we provided coaching around weight loss with applications for his phone to track physical activity, recommendations for workouts that he was able to do at home, as he was understandably concerned about working out at a gym or anywhere else because of COVID. And he certainly appreciated and made use of those resources. He was also provided nutrition education, giving him meal planner resources and information on the DASH diet. And his blood pressure at discharge was 132/84. And I think this is Tanya.
Yeah, that would be me. I pretty much know most of the folks on the call, but in the event that I do not, so my name's Tanya Doherty. I am the population health pharmacist in Center City. So I was the pharmacist team member participating in this project. And the first thing we did in implementing in the start of this project was provider education. So I conducted 3 educational sessions for our providers at JIMA, and the staff actually were invited as well. So updates in lipid management, and myself, along with our embedded endocrinologist, presented case-based studies and evidence-based review of the newer agents in diabetes management. We also, I also did kind of a workshop on continuous glucose monitoring for diabetes management. And so I know Sandra had talked a little bit about the referrals that pharmacy would receive or myself would receive in terms of our assistance with helping patients with adherence, medication education, but also modifying doses of medications, as well as taking away medications that were inappropriate or possibly contributing to hypertension or worsening diabetes. So we were all part of that process as well. And having the intake in place was really key to my involvement so that I could target patients. Next slide. Along with the larger practice-based education, I also provided quarterly scorecards, both a practice-based scorecard as well as a provider-specific scorecard around statin use in patients with diabetes. So one of our other focus was to look at preventing cardiovascular events in our high-risk patients with diabetes and focusing on assuring that they're on statin therapy, as well as checking for adherence for statin therapy. And so this is just an example of what I would share with the providers during our quality meetings, as well as our individual practice meetings with the providers to show them where there are in comparison to both other practices as well as to their peers. So this is just an example of what was provided. And I also provided patient lists for those providers who were lower performers, which was very helpful for them to target their patients. Next slide. And these are showing our results of our statin implementation and all of the, education, as well as the scorecards that we shared with providers. I will talk about some enterprise initiatives that might have also driven some of these statin prescribing measures that you see before you. So if you look at this slide, basically it's a graphical representation of our statin use in diabetes, specifically for JIMA, starting with October 1st of 2019. And on a quarterly basis, you can see how despite all of the issues during the last year, we've done quite well in improving our diabetes statin measures. We've improved it by 7%. We started off at 74% and currently are at 81%. So 81% of our patients who at JIMA who have diabetes are on a statin. So I'm excited to see those results. And just by way of background, the denominator is about 1,750 patients at any given time. So this represents an increase by about 150 patients over that time frame for the statin prescribing. Next slide. I alluded to that there were a number of enterprise initiatives around improving our statin quality measures that myself were involved in, Dr. Ward, as well as Bracken Babula, who is our developer of a lot of these measures and implementation that we had developed within our electronic health records. So I'd be remiss if I didn't talk about these, because these certainly contributed to our success at JIMA, and you can see it contributed to the success for our enterprise in Center City as well. Essentially, we developed a new health maintenance topic for statins. So if a patient had a diagnosis for ASCVD or diabetes, or they were not prescribed a statin on their active med list, they would receive a health maintenance topic alert that the provider would have to address. Now on the left-hand side, that's a screenshot of what the health maintenance alert would look like, the statin therapy, along with other alerts like influenza vaccine, Hep C screening, etc. And if you do click on that, it will then actually guide the provider to order either a moderate intensity or high intensity statin, depending upon if the patient has diabetes or ASCVD. And on the right-hand side, you can see the use of our health maintenance topic was fired and used. About 96 patients had their statins ordered directly from this health maintenance tab. So this showed us that it was being effective in terms of prescriber behavior for our providers. Next slide, please. Another tool that was implemented prior to this project was our Adherence estimator tool, which essentially, when you're within an office visit encounter, this is a visual alert for providers showing if a patient is adherent or potentially non-adherent to their medications. And this is a direct link to SureScripts data at the pharmacy level. And you can see anything in green is greater than an 80% proportion of days covered where the patient's adherent to their fills. Yellow would be 60 to 80% and red would be anything less than 60%. And you can basically hover over each one of these, what I call bubbles, to see when the patient last had their prescription filled. So this is a nice visual representation or alert for patients who might be non-adherent to any medication, actually. Next slide, please. Another enterprise implementation was the Mayo Clinic Statin Decision Support Aid was implemented within our EHR. This is, anyone has access to this, and basically it's a tool that will automatically download a patient's LDL, their age, their smoking, et cetera, all of those things that go into the ASCVD risk calculator to come up with their specific risk of having a heart attack if they were on or not on a statin, so that you can really have a visual conversation with the patient about their decision to start a statin. And this is very helpful specifically in the patient and in our diabetic patient population when having that conversation. And in terms of what I was alluding to in terms of our overall Jefferson Center City primary care statin use data, if you compare to JIMA's to what we have seen around the primary care practices, you can see we've increased exponentially looking at year 2019 and year to date to 2021. We've improved significantly both 8% in our diabetes statin use measures, as well as even our ASCVD statin use measures. So those will be continuing, and we're hoping to expand upon the program in the upcoming year. So you can click through, thanks, Sandra. So our project implementation challenges and solutions were numerous, but came up with solutions. Obviously, it's very challenging for another task for a provider to implement within their workflow when they're seeing patients. It's a challenge to engage patients and have a conversation about starting statins. I have received many referrals to help patients starting statins to, quote, convince them. And it does take some time, but it's certainly beneficial and positive in the end. And it's difficult in terms of if a patient doesn't come in to see the provider, you know, with the last year, it's very challenging to have that conversation with patients. And so what we tried to do was automatically do 90-day supply fills. We have a list of patients who were on 30-day fills that we automatically switched to 90-day fills. We did patient outreach for patients with statin gaps, honestly, just to get them in to see the provider. And then we actually alerted providers with reminders in the chart that the patient's overdue for a statin or meet statin criteria to consider prescribing a statin. Of course, I had mentioned I had received referrals as well. And again, all of the enterprise tools that we had implemented as a team really helped to drive a lot of these measures as well. And so I'm going to let Dr. Ward kind of discuss our program next steps and what we're going to be doing in the future.
Sure. So our next steps are going to be focusing on our biggest challenge has been identifying patients who are eligible for health coaching. And so we're going to be working on that. Obviously, you know, COVID continues to present some barriers. And we're working on some things around a variety of aspects of utilizing MyChart for patients that are on that. But we also have to think of ways not just to use the portal to be able to access some of the harder to reach sets of patients. We can use MyChart to actually do some health coaching for the people that are on it, reminders, and it has a lot of functionality, and we hope to be able to use that really to the top of its ability. We've had, obviously, you know, from what Tanya presented, we've had a lot of success in actually increasing the amount of people that are using statins across the entire practice. So we are monitoring the use of this among our clinicians, and we're going to continue to do that and give them feedback. And that's actually a part of a monthly scorecard that we give them, as well as at a practice level, as well as an individual level, and then they have access down to the individual patient. The EMR, you know, is kind of always a solution for a lot of this stuff, but it does honestly help us create something that is sustainable because it's ingrained in our workflows through the EMR. And that's how we use the EMR, is because that is really the engine for our workflows, to be able to both assist patients, but also to identify patients who are good candidates for statins. With, again, through this program, especially a focus on the uncontrolled diabetics. And again, this, you know, with what we've been able to do, we have some ideas for additional ways to be able to work on adherence. So I think we've done a very good job with prescribing. What we still need some work on is adherence. We actually have pretty good adherence numbers, but there are, I think, a few tactics that we can do to improve clinical decision making, to put people on statins, and then adherence going forward. And, you know, the patient comfort with utilizing statins, there's still a lot of It's like vaccines. I mean, there's like so much if you go onto the internet about, what statins do to you. And I had one patient come in and say, I don't want to go on a statin because I don't want dementia. It's overcoming those sorts of things. And clinicians, about the number of clinicians that start statins, their side effects, and how do we deal with those. And again, continuing the reporting and feedback to the clinicians on their utilization. I think that's it, right?
Well, thanks, everyone. Thanks, Larry, Tanya, Sandra, and Emmy. Really appreciate that. Lots of different interventions and targeting the patients directly with coaching, working through your electronic health record system. I think that's great. One question I have is, considering kind of the cohort of patients you chose for this, the high-risk cardiovascular patients with diabetes, have you given any thought to looking beyond the statin initiation and management to some of the newer diabetes agents? I know, Tanya, you mentioned presenting to your colleagues about these agents and patient selection. It seems like there's maybe a natural add-on to this project that could target those particular therapies. Is that something that you're planning?
So you're absolutely right. I actually gave grand rounds on this today. And I presented the data that we got from you all as a part of that. Just happened to be today. Between this and a project that's being run with endocrinology and Dr. Lev, we and now an upcoming one also with Dr. Simon of endocrinology, I think there are definitely possibilities for, I think, first just having people understand the power of those drugs and incorporating that into changing practice styles and prescribing habits. So that is something that we're definitely looking at. And again, I think Dr. Lev is a part of that, and something that we'll incorporate in what we do going forward, I believe.
Then one other question, as you were enrolling patients for this, recognizing the challenges with COVID and general outreach to get patients in and commit to something like this, did you have a sense of kind of your success rate? How many patients did you target versus how many were enrolled? Just kind of curious how challenging that is quantitatively.
I think the biggest challenge is getting the patients. Once we identify the patients, I think they've been very receptive. Not 100%, but they've been very receptive with good success. We just have to. I think we've had some challenges with just sort of our staff commitments and the actual identification of patients. But I think we're working to smooth those out. And once we do, I think what we offer patients is good and their response is positive.
Then you mentioned the coverage of health coaching. Is that an insurance issue for a lot of folks? Does it just depend on who they're insured by that determines whether or not they're covered?
So the health coaching isn't covered by insurance. It's something that we've been able to fold into. One of the ways that we've been able to provide it is through grants like these, navigator positions where there's an opportunity to do something similar can be folded into some of the funds that we receive through CMS programs to support comprehensive primary care. But part of the reason why we're excited about the use of MyChart and Epic, and maybe even someday texting, is that, it was sort of a solution to a challenge that we had because of COVID, but it's also a way to, we also use this as an opportunity to pilot a different way of providing health coaching and consistent communication with patients, sending them evidence-based information via MyChart about how to improve their health, remind them to come in to see their PCP or get their labs done to take their medication. Because it addresses some of the cost concerns, Greg, that you mentioned, and it also is a really turnkey way to communicate with patients from a variety of different backgrounds and needs. It's just easier than getting on the phone with somebody for 20 minutes, 30 minutes,
Sure.
Once a week or once a month, just like, oh, right, you reminded me to take my medication today, and I will. So, we really view that initiative as a creative solution to a problem, but also a way of really creating sustainability around some of the work that we're trying to do, and hopefully a pilot for creating these sort of epic-based campaigns for a number of chronic conditions, not just diabetes and hypertension.
Any other questions for the Jefferson team here?
Tanya, I had a question. When you talked about the enterprise-wide solutions that are part of the EMR that it's used in JIMA, and you had the results for that, do you have a sense in like family medicine if they are using the decision aid tool or some of the other enterprise solutions?
Yeah, they are using it. It's probably like a 50-50 split, to be completely honest with you. Family medicine utilizes these tools equivalently to internal medicine. And they have, and I present all the practice scorecards, et cetera, for family medicine as well, similar to our practice transformation folks and our quality folks when we meet. And yes, they are using it, and we're hoping to kind of expand that as much as possible in the future, as Larry alluded to things like adherence, which is naturally the next step when it comes to chronic medications.
Right. And what about, and I don't know if Yair's on the line, if is it being used in or Tanya, do you know if it's being used in cardiology division also?
It's available for those cardiology. I will say that Yair and I had a discussion, and I kind of taught him some of these tools to use, because it's possible they're underutilized, and that certainly is something we can look into to see if there's the potential in that arena to kind of do some education around that. A lot of times, especially when it comes to diabetes, these medications are started in primary care, but not exclusively. So that is a good suggestion to potentially expand and make sure everyone's aware of some of these tools.
And I guess also too, the adherence estimator, that would be something that in endocrinology or cardiology could be using those tools to see if the patients are staying on the SGLT2s or GLP-1s.
Absolutely.
Okay. Good to know.
And for me, the biggest barrier is cost. And so, these tools can be used also to see if patients never even picked up their first dose of an SGLT2 or GLP-1 and target that patient population. I do a fair amount of assistance with patients with the cost of these medications, and we're trying to develop something globally to better help patients in that arena. And I think that would go a very far way when we're targeting this patient population and give them and practices tools to help navigate the cost of these medications, because it's quite complex.
Great, thank you.
Can I make a comment? This is Yair. I think I can, I think that this is really exciting, and congratulations for what you've done. I think in cardiology, we'd like to take it even a step forward, because we do believe that people with coronary artery disease, either a clinical event or coronary artery disease that was detected by a CAT scan or whatever, they should not only be on statin, yes or no, but we should target.
Here, did we lose you? Did I lose?
No,
Anyone else use Larry?
Yair, you dropped off.
I think we lost
barrier.
Oh, there you go.
You're back.
Can you hear me? You lost me?
Yeah.
Now we lost about the last
Rewind 10 seconds.
Oh, sorry about that. My connection here is not so great. But what I was saying is that I think that we would like to look also in cardiology, not only statin or no, but beyond that in terms of medications based on the LDL levels, risk factors, known coronary artery disease, event or no event, and augmentation of the maximally tolerated statin, including ezetimibe and an injectable PCSK9. I will say that, some of the initiatives that are doing it are very exciting, but I have to say that, and I was discussing it with my boss, it's on a divisional level. We don't have so much, it's something that we have to figure out, because, for example, if we have somebody who is dedicated to help us, like Tanya, a pharmacist who can, or even one of the things that we're thinking about, Christine Clancy, one of the nurse practitioners of Endo, is now helping us, but in a very, very minor scale, just in the research project that we previously described here. But we don't have any APPs in the practice, nor pharmacists. So I think that, nor people like Bracken, who is the guru and the magician of all epic. Like nobody in cardiology knows how to do what he does, create rapport, do this, do that. We don't have anybody like Tanya. And I think that in order to generate successful project like yourselves, it will be, you know, it will be very important for the division of cardiology to you know, in the SGLT2 and statin therapy, whatever, is to have dedicated human resources that can help us.
Thanks here. Yes, challenging. I certainly don't have the answer to that, but you know, cost benefit analysis of some of these and newer agents potentially reducing events. I think it's a tricky proposition. I haven't really seen a lot of that long term in terms of the literature, but certainly worth thinking about. Any other questions or comments before we call it an evening here? I see Roy lining up for a question. I can't tell that, but he's on mute. You're on mute, Roy. There you go. Oh, still can't hear you.
Oh my goodness. We can't hear you at all. Check your keyboard. Sometimes people mute from the keyboard and don't realize it. Type it
I'm
in.
out. So if you guys don't know already, Roy and Elise live in the same house. They're married. So
Oh, he's just going to go to her room, or else he's hand on the screwing. I don't know. I wasn't sure. There we go.
I guess that's one way to solve a technical issue. Space bar unmutes.
Yep. Okay.
Ah.
Sorry.
Okay, I forgot my question. I think
I was gonna
what I wanted to ask, I mean, it's great to see metrics applied to quality improvement. That's one of my bugaboos that institutions we've looked at across the country, doing good things, but not knowing whether or not they're effective. But I guess the bigger question for a place like Jefferson, which has such a sprawling catchment area with lots of suburban and Jersey practices and the like, and even across departments, what mechanisms exist in Jefferson to help, you know, sort of scale out these good ideas on a broader basis and ensure they are sustained over the years without, you know, the individual efforts of, you know, people like Yair and Larry at the departmental level?
I think the statin stuff has really been, you know, we've worked to make that sustainable and ingrained. You know, a lot of this is kind of catching up from years of not doing the right thing and, you know, getting these people on it, you know, and creating things like the best practice advisories in the EHR. You know, the training about how to, you know, deal with patients who are intolerant of statins, the health coaching, you know, these are the things that this sort of project allows us to demonstrate the utility of. And if we're able to show this, you know, we have struggled with two main areas. One is the control of hypertension, and the other is diabetes control. So if we're able to identify this as a method to be able to improve diabetes control and hypertension and, you know, and coronary risk, then we can apply this on a, you know, a high risk group, and, you know, and have a method for us to be able to do this. So this is really sort of a proof of concept of whether this sort of intensive monitoring works. And if it does, then it's something that we can implement on a wider basis.
Well, I guess I was asking, what does Jefferson have any, you know, broader sort of executive level or interdepartmental level where, you know, people are cooperating and, you know, trying to extend these good initiatives?
Yeah, well, I mean, we have a whole population health department. I mean, so that's what I'm saying. If we can convince them, you know, that this is the type of thing that works, and we can show the proof of concept of that. That is our enterprise-wide group. And, you know, and especially now, you know, our ACO next year is going to have 3 metrics, 3. One is depression screening, one is A1C control, and one is hypertension. So, you know, if you want a way to focus us and look for ways to improve these and make it enterprise-wide, give us just 3 quality metrics and it'll focus attention on those pretty quick.
And one other comment, years ago, we worked with a cardiologist on a dyslipidemia project. And one of the things he put into it that was so helpful in getting people to want to accept statins, instead of telling them about their cardiovascular risk, he translated into heart age. So if you're a 50-year-old person with a heart age of 75, that was very motivating, as opposed to just saying that you're increased risk of heart disease and need a high-dose statin. So just a tip that seemed to be efficacious in the past.
Absolutely. It's just ways of translating into ways that people understand.
Exactly.
Absolutely.
Okay, well, thank you, everyone. Really appreciate your time this evening, and we'll look forward to the next gathering. I actually don't think we have one scheduled yet, so we have a couple folks to hear from. We're going to be hearing from our Health Share Exchange colleagues, talk about some of their data analyses and capabilities that are looking regionally at the same issues, and we'll keep you posted on that. And until then, have a great night. We'll talk soon. Thank you.
Thank you.
Thanks, take care.
Bye-bye.